So we can get disorders of both the primary hemostasis and the secondary hemostasis. So the primary hemostasis, what do we say was the main mediator of primary hemostasis? What blood cell or what part of the blood? Remember the main mediator was the platelet. So disorders of primary hemostasis come from either whether the plates don't work well or you don't have enough platelets. And what's going to happen is you're going to get, this presents with bleeding and mucous membranes and skin. So some things like just minor things like nosebleeds, bleeding gums, small GI bleeds. Other thing you can get is petechiae, which are pinpoint bleeds under the skin. So this is a petechiae. These are pinpoint bleeds, small, tiny, like dots of blood. That's a petechiae. And what's going to happen in your lab findings? Well, what's going to happen to your bleeding time, which is basically how long does it take to clot if you have a problem or to stop bleeding, and if you have a disorder of primary hemostasis? It's going to have increased bleeding time because you have a problem with platelets and you need the platelets to form that platelet plug. Now, the other thing on labs, you may have a decreased platelet count. It depends on the etiologies we just said. You can have lowered platelets as you see here, or just they don't work it well, but you have normal levels of platelets. Finally, what's going to happen to your PT and PTT? What do we say? We said PT and PTT was part of the secondary hemostasis, so what's going to happen to these levels? They're going to be normal. There's nothing wrong with secondary hemostasis. This is a problem in primary hemostasis. So, again, primary hemostasis presents with these minor bleeds of the mucous membranes in the skin. You get these small little petechiae. If you go look at the secondary hemostasis, what was the main mediator of secondary hemostasis? We said it was clotting factors. So if you're deficient in clotting factors, or you have an acquired inhibitor to clotting factors that makes them not work, then you get disorders of secondary hemostasis. And the way this presents is just a little more severe, a little more strong. So you get deep tissue bleeding into joints and muscles, and you get large palpable ecchymoses. Ecchymoses is a fancy term for a bruise. And a bruise, what is a bruise? If you ever had a bruise, it's like that. What it is you have a larger bleed under the skin, and it's going to turn color. It's going to, as the blood cells break down, and that's why you get that bruising color, and that's in large palpable ecchymoses. Okay, and then finally you can get rebleeding after surgical procedures, and especially what they talk about a lot is after a dental procedure, after wisdom tooth removal. You can get a lot of rebleeding, and that might be a sign of a disorder of secondary hemostasis. So how do we test this? What findings in the labs will we get? What will happen to your PT and PTT? Remember, we said that PT and PTT reflect the clotting cascade. Remember, what did we say? This was the intrinsic or the extrinsic. Remember, PT was the extrinsic. Remember, that's shorter, and PTT was the intrinsic pathway. This was the longer pathway, and these will be increased. If you have problems with clotting, you're going to have longer times to stop bleeding, so you're going to have increased PT or PTT. So basically, that's primary hemostasis, problem with the platelets. You get minor bleeding. Secondary hemostasis, problem with clotting factors. You get more larger bleeding. You get deep tissue bleeding. You get large palpable ecchymoses. Okay, you get rebleeding after surgery procedures. So we're going to talk about disorders of primary hemostasis now, so specific disorders. First one is Bernard-Soulier syndrome. This is due to a defect in the platelet GP1B receptor. So we said, what do we say GP1B was needed for? It was needed for that platelet to bind to von Willebrand factor. And so what's going to happen? First of all, you're going to see large platelets on a blood smear. You're going to get an abnormal Ristocetin test. A Ristocetin test normally causes von Willebrand factor and platelets to stick together, and that's through the GP1B receptor. So if it's abnormal, though, you're going to have problems with this sticking right here, because you have a problem here. So you're going to have an abnormal Ristocetin test in Bernard-Soulier syndrome. Next, Glanzmann thrombasthenia. This is a problem in the GP2B 3A, so that's this one right here. And what's going to happen? You're going to have impaired platelet aggregation. Where that's the point of this. You need this, and you need fibrinogen to get this platelet aggregation. So what's going to happen is you're going to see blood smear that shows no platelet clumping. Platelet clumping is just basically aggregation of platelets. Finally, uremia. Uremia just disrupts platelet function, impairs those blocks both adhesion, which was right here, and aggregation, which is over here. Okay, so that's uremia. So these three. Okay, next is immune thrombocytopenia. As you can tell from the name, it's immune and it's low platelets. Okay, so you get antibodies targeting the GP2B3A receptors, and you're gonna get these antibodies here, and now you're gonna get a platelet antibody complex, and it's gonna get cleared by the spleen. You get thrombocytopenia, fancy word for low platelets. Etiologies can either be idiopathic or triggered by viral illness, drugs, or cancer, which can trigger immune thrombocytopenia. The treatment for this is immune disorder, so you can give them steroids, you give them IVIG. Okay, if these don't work, you can do a splenectomy. And why would you do a splenectomy? What do we say? What do we say happens? We said this complex, the platelet antibody complex, is cleared in the spleen. So you take out the spleen, you don't get clearing, you don't get thrombocytopenia. So that's it for immune thrombocytopenia. Next is thrombotic thrombocytopenic purpura. We talked about this already in the renal lectures. So this is due to inhibition or deficiency in the atom TS13. Atom TS13 is normally needed to cleave and inactivate von Willebrand factor. You have deficiency in this, you get overactivation of von Willebrand factor, and so too much von Willebrand factor leads to platelet over adhesion, over aggregation. What's going to happen? You're going to use up all these platelets. These are going to get used up. They're going to aggregate and they're going to get used up. You're going to get thrombocytopenia. Now you have too much platelet plugging of your blood vessels, and now you're going to get when your blood cells try to pass through, they're going to get sheared. They're going to get sheared and they're going to get destroyed, and you're going to get anemia as well. So this is termed microangiopathic hemolytic anemia. So you get overactivation of platelets, you're going to get consumption of platelets, you're going to get low platelets, you use them all up, and then these minor clots are going to cause shearing of the red blood cells as they try to pass through all these clots. The red blood cells get hemolyzed, you get anemia. Okay. Next is the hemolytic uremic syndrome. It's a similar idea, but except for that it's caused by infection by Shigella or E. coli. And what you get is you get production of Shiga toxin, causes endothelial injury. We said, remember, how do we get all this hemostasis? When we get endothelial injury, get that subendothelial collagen exposure, you get platelet aggregation, and then you get the same thing. You get platelet aggregation, what do we say? We said platelet aggregation leads to consumption, so low platelets, and then you get all these platelet clots, and then your red blood cells are going to get sheared as they pass through, you get anemia. So that's what microangiopathic hemolytic anemia comes from. So, broad picture thing, these three right here are due to platelets not working properly. There's no low level of platelets, there's no thrombocytopenia. In here you just have a problem with the GP1B receptor. Here you have a problem with the GP2B3A receptor, that's Glanzmann thrombocythemia. And then uremia just disrupts both of their function of adhesion as well as aggregation. And these three are due to low level of platelets, and just because of consumption, first, these two are due to consumption. We use too much of them. This one is due to immune problem. It's an immune problem with antibodies that attack the GP2B3A receptor. I want to go into the hemolytic uremic syndrome and the thrombotic thrombocytopenic purpura again. Again, this is already in the renal lecture, but I want to talk about it again. Clinical features are the FAT RN. Okay, FAT RN stands for fever, anemia, thrombocytopenia, renal injury, neurologic diseases. And the other thing here you see here is the recent diarrheal illness, because what did we say? What were the bacteria that causes this? It's either Shigella or E. coli, and those cause diarrheal illness. Okay. And the key thing here is that hemolytic uremic syndrome is more of the renal and less of the neurologic symptoms, and we remember that because the uremia. Uremia is from the kidneys, build up of the urea. That's how we remember that there's more renal symptoms. Okay. And the way we treat this is with plasmapheresis. Next is the thrombocytopenic thrombotic purpura. Same clinical features. These are both microangiopathic hemolytic anemias. So you get the same things. You get low platelets from consumption. You get low red blood cells from the shearing, and then you get all these inflammatory factors. You get damage to these because of obstruction of the vessels, obstruction of the kidney, obstruction of little brain vessels. And that's how you get damage. And then TTP has more neurologic problems and less renal problems, and there's no recent diarrheal illness. Similar treatments, you get plasmapheresis and steroids. So this fat RN, that's how you remember it. Schistocytes happen when you get that shearing, so that's what you would see. So that's it for primary hemostasis. Now we're going to go to secondary hemostasis. So first one is disseminated intravascular coagulation, DIC. You hear that a lot, DIC. This is a consumption coagulopathy. So this arises from too much coagulation. There's widespread activation of clotting. So you can get shortage of clotting factors because you're using them all up. So decreased clotting factors. And you're going to also use up too much platelets. So decreased platelets. Okay. Now if you have shortage of these, now you're going to have impaired hemostasis where you need it. So that's a consumption. So you're using too much. And coagulopathy means you have impaired hemostasis. So these patients, they can have bleeding from body orifices and IV sites. That's from impaired coagulation. And the other thing they can have is they can have problems from thrombosis as well. We said this is from overcoagulation. Okay, so they're gonna have problems from both overcoagulation and bleeding in DIC. The reason why we can get DIC, remember we said it was from overactive clotting, widespread activation. There's the three things: delivery, infection, and cancer. That's DIC. Okay. Delivery is because you have tissue factor in the amniotic fluid that activates coagulation during birth, and then you have infection. You have all these inflammatory markers that cause coagulation, and then finally cancer. Cancer is a hypercoagulable state, so you can get widespread activation of coagulation. And you get DIC. So, what labs would you see? Labs would be decreased fibrinogen from consumption of all these clotting factors, and you get increased D-dimer from splitting of fibrin. Okay, decreased fibrinogen, increased D-dimer. Where fibrinogen was factor 1, which we said gets activated into factor 1A, which is fibrin, which is all that fibrin cross-linking. Eventually, you get all this fibrin cross-linking. It's going to get breaking down. You're going to get increased D-dimer. Okay. Now I want to add that the DIC is a disorder of both secondary and primary hemostasis, and we know this from here. You get problems with clotting factors, you get problems with platelets. So you get problems in both secondary and primary hemostasis. There's a similar thing in von Willebrand factor disease. Let's clear these words. Von Willebrand factor disease is a deficiency in von Willebrand factor. It's inherited, and you get impaired platelet plug formation. So remember that we need what was the function of von Willebrand factor? What do we say? It binds to the subendothelial collagen. Platelets can come and bind to it. Which receptor do they use? They use the GP1B receptor to bind to von Willebrand factor, and this doesn't happen if you have a deficiency. So you get that primary hemostasis symptoms. What do we say were symptoms of primary hemostasis? Remember we said it was petechiae, and we get the minor bleeds, so minor skin and mucosal bleeds. The other thing to note is that there's also increase in PTT because you need von Willebrand factor to carry and protect factor 8. Okay, remember PTT was part of the intrinsic pathway. It shows you there's a problem in intrinsic pathway, and because if you have decreased von Willebrand factor, you can't carry or protect factor 8, so you have a problem in that intrinsic pathway. However, you usually won't have symptoms of secondary hemostasis. So while we're at it, what were the symptoms of secondary hemostasis? Remember we said that it was the deep tissue, deep joint bleeds. You can have that large bruises, aka ecchymoses. You can have that surgery rebleeding, and you usually don't see this in patients with this inherited disease of von Willebrand factor disease. Okay. Next is hemophilia A and B. This is super simple. It's deficiency in factor 8 and 9. Okay. Factors 8 and 9 deficiency, X-linked recessive inheritance. You get hemophilias. Okay. You get the impaired clotting ability. Vitamin K deficiency. What do we say? What do we say for vitamin K deficiency? This is a review. I already talked about this. Remember, vitamin K needed for activation of factors 2, 7, 9, and 10, as well as protein C and S. And 2, 7, 9, and 10 are coagulation factors. If you don't get activation on these, you have problems with coagulation. You get bleeding, and that's secondary hemostasis. Finally, we have clotting factor inhibitors. So this is when you get an acquired antibody against a coagulation factor, and that leads to impaired function of that clotting factor. Okay. the way we treat this, the way we diagnose this, is with a mixing study. So how do we do a mixing study? What happens is you add normal plasma to a patient's plasma. Okay, so let me break this down. So our patient here has antibodies against their coagulation factors. So they're bleeding. So if you add normal plasma here, you give some normal plasma with all these guys have clotting factors and antibodies. You add some normal plasma with clotting factors. What's going to happen? Are they going to have better symptoms? Are their symptoms going to improve with the addition of this this normal plasma? The answer is no, because these patients have all these inhibitors in their blood, and they're going to bind to those new clotting factors from the plasma, and so you don't get improvement. That's an abnormal mixing study. A normal mixing study is, let's say, a patient with hemophilia where they just don't have clotting factors here. You add normal patient's plasma with all these clotting factors. Now this patient is going to get blood with clotting factors, and they have resolution of their bleeding. They get regulation. Their PTT levels become more normal. So that's a normal mixing study. And here it's a mixing study that's abnormal. Again, you just mix plasma from the patient and mix plasma from a normal person, and you see if their coagulation improves or not. So abnormal and clotting factor inhibitor. Okay. So again, these are secondary hemostasis problems with the clotting factors. These two here are disorders of both secondary and primary hemostasis, and these are just missing stuff. You're missing factors 8 and 9. You're missing vitamin K, so you don't get activation. And this one, you have an inhibitor that inhibits clotting factor function. So now this is a whole overview of what we just talked about. So primary hemostasis, what was the problem? Is problem with platelets. So either too little platelets or your platelets don't work. And how does this present? What would the labs be? We said labs would be increased bleeding time, and the presentation was from petechiae and the small little skin tissue mucosal bleeds. Just want to add, this is the last part. This is an overview of what we just talked about. You can skip over it. I'm just be quizzing you on what happened. So we said platelets not working or too little platelets. Okay, so causes of platelets not working. What do we say? We said Bernard-Soulier syndrome. What was that? What was the problem there? It was GP1B receptor problem. What was the next one? Glanzmann thromboasthenia. What was the problem there? That was the GP2B3A problem. Finally, uremia. What was the problem? Uremia just impairs platelet function. Okay, so that's the three. And then quantitative platelet disorders, that's due to platelet destruction or consumption. What were the three? Remember, we had ITP, immune thrombocytopenic purpura, and then we had the two microangiopathic hemolytic anemia. So with TTP, HUS. Okay. This one, do you remember what was the problem? From the name, it was autoimmune antibodies targeting the GP2B3A receptors, and then the antibodies and the platelets get destroyed in the spleen. You get low platelets, you get problems with hemostasis. Now, mixed disorders. What were the mixed disorders? First of all, how would it present? How would it present on the labs with the bleeding time and the PT/PTT? Well, we have problems with both primary and secondary hemostasis here. So we have increased bleeding time, increased PT or PTT. And what did we say? It was von Willebrand factor disease and DIC. So von Willebrand disease, remember, what were the symptoms? Were it more primary or more secondary hemostasis? I told you it was more secondary hemostasis because, again, it's the key part of its function is to help platelets bind to the endothelium, subendothelium. And finally, DIC allows us to overactivation of clotting factors, leads to consumption of platelets, consumption of clotting factors, and then you can get bleeding. So you get both thrombosis and you get bleeding. And then secondary hemostasis, how does this present? Remember, on labs, you get that increased PT/PTT. You can get deep tissue bleeds, deep joint bleeds, you can get surgery bleeding. And then what were the things? So remember, we had hemophilia A and B. What was that? That was deficiency in clotting factors 8 or 9, respectively. And then we had vitamin K deficiency and clotting factor inhibitors. How do we diagnose clotting factor inhibitors? When we just do a mixing study, and that's if their PTT doesn't improve with the mixing of blood, you know you have a clotting factor inhibitor. So that's it for our disorders of hemostasis. It's a big I guess a lot of things we covered, but hopefully it makes sense. This is a big overview slide.